guys, welcome back to the Book of Perfusion by Ijaz Hidayat. So today we have Mr. Ijaz with us. Hello Daddy, how are you?
I'm good, beta. क्या हाल है? How are you?
Daddy, I am very well. So Daddy, today we have a very interesting topic. Can you please explain us that what is the Marfan Syndrome and what is the effect of the Marfan Syndrome to the patient's heart and what will be the complexities or the protocols for doing the surgery, like the heart surgery for the patient having Marfan Syndrome?
Good question. Very long, lengthy question, but I will try to answer in a short and a brief. So, and I will going to just select the part which is related to the perfusionist and for the Hurling machine. The Marfan syndrome is inherent in disorder, and it's going to affect your actually the connective tissue, and it make your connective fragile the connective tissue, and it affect on the different parts of the bodies like in a heart, blood vessels, especially in your eyes, bones. So we going to talk related to the heart, because as we are the perfusionists, we're going to talk about the heart. Usually you get aortic dissection, aortic aneurysmal, because this Marfan syndrome patients height is tall, they're taller, mostly their height is more than as the usual person, and the connective tissues get be compromised, fragile due to the inherent disorder, and usually you got like aortic aneurysm or aortic dissection which need to be repaired, and even sometime you get a problem with your mitral valve prolapse. So in the Marfan syndrome patients, we have to take care so many measurements during the cardiopulmonary bypass, and usually you will find the patient's aortic dissection or aortic aneurysm, and we'll go one by one how you're going to manage as a perfusion during the cardiopulmonary bypass. So first we'll talk about the intraoperative management during the cardiopulmonary bypass by the perfusionist. Number one, we'll talk about the cannulations. Okay. So in the Marfan syndromes, we are not cannulating in the routines like aorta, and why not aorta? Because in aortic there is a, as you know, we have the dissection or aneurysmal, and it can make a more traumatized the time if you're going to cannulate the aorta, ascending aorta. So the preference cannulation for arterial cannula is either you cannulate axillary, or either you can cannulate the femoral artery, so which is going to help to prevent.
Sorry, but I think we can do the central with the aorta.
We can do the central, but the preference is to try to, especially in the case of when, no, two things now, very good question from you. Usually if your arch is involved, if your aortic arch is involved for aneurysm or dissections, then it is difficult to cannulate the part of the ascending aorta. So try the preference, as I mentioned, to prevent traumatizing the patient. We prefer, as a surgeon, prefer to cannulate either ascending, either axillary artery, or either you can cannulate the femoral artery is the ideally. But if you have the access for the ascending aorta, you can cannulate, but most usually like in aneurysmal cases, usually in the aneurysmal or aortic dissection cases, a surgeon preference is to cannulate either an axillary artery or either you can cannulate the femoral artery. Okay. And once you cannulate the femoral artery or axillary artery, then you can open your sternum and keep ready with the blood salvage techniques like cell saver. This is a preference of the surgeon for the cannulation, and like the case like a mitral valve and the patient having the Marfan syndromes, and still the aortic root is okay to cannulate, you can cannulate central cannulation, but mostly if the patient like came with the Bentall procedure or aortic dissection or aortic aneurysms, and your brachiocephalic artery was involved for dissection or aneurysmal, then you have to cannulate like a axillary artery, or either you can cannulate the femoral artery. Then you can open your sternal with the blood conservation technique as mentioned with the blood salvage techniques. So keep cell saver ready. So in case of any massive bleeding, and you keep your the circuit ready to go on a bypass, and in the meantime you be smart with the, in case of emergency, to go on a sucker bypass. Sometimes you will not able to get due to the rupturing of aneurysm. You just cannulated the femoral artery and then you're going to open the sternal, and you didn't get a chance to cannulate a bicable, or you can just go through with the cell like a sucker bypass, and then you can cannulate your SVC or IVC or right atrial appendage, whatever, as per the preference of the surgeon. Or you can cannulate the femoral vein even, and with the wet sports, and you can go and bypass, and then you can repair. Now, cannulation completed.
Yes.
Now we'll talk about the perfusion management,
Management.
sir. So the first of all, don't keep the pressures above than the 70, because the patients the connective tissues are fragile. So try to keep the pressure around a 50 to 70. Don't go more than the 70 to avoid any further dissections or any hemorrhage due to the fragile tissues. Connective tissues are fragile. Secondly, if the procedures are going to be finished in hours or something, to keep the normothermia. But if you need to go for the deep hypothermia, like hypothermic arrest, in case of you need to repair your do the Bentol procedure or aortic aneurysmal procedure or arch repair, you can decrease temperature and then prefer advise to do the antegrade cerebral perfusion or retrograde cerebral perfusion and your pump flow, and you're going to stop the lower part circulation and and go the antegrade cerebral perfusion for like about continuous or sometimes intermittent. Cardioplegia, in a previous time we used the blood cardioplegia, but nowadays, as you know, the custodial cardioplegia or Delnido cardioplegia is available. So if you are using the Delnido, or either you're using a custodial, you will get a long time to keep the heart stop, like 120 minutes with the first dose of your custodial or either Delnido cardioplegia, and so surgeon can easily work on the arch and can repair the arch or can repair the buttons. Always manage your lactate level, and especially for the long rest time and preservation of your heart muscles. So be smart to manage your blood gases. So your blood gases can be in a normal ranges. Always keep your pH level around 7.35 to 7.45. PCO2 should be in a normal range, like a 35 to 45 millimeter per mercury. Focused on your lactate, focused on your acidosis of the patient. So keep to calculate, as the last time I have given one talk regarding the goal directed perfusion. So your target of perfusion during the cardiopulmonary bypass, especially in the Marfan syndrome patients, keep the goal directed perfusion. The index of the goal directed perfusion, the DO2 index should be around 280 mils per kg per minute per meter squares, and manage your blood gases. So this is from my side to how to manage your Marfan syndrome patients, especially the patient who will going to go on a cardiopulmonary bypass, especially on heart-lung machines. So your blood conservation technique will be going to be one of the major key element. Second technique is with the key elements, especially in a massive bleedings, your cell saver should be there. So keep the blood cell which equipments available to keep the patient's own blood to be transfused back. And secondly, try to manage the patient on bypass with the mean pressure of 70 to 650 to 70 millimeter mercury. Cardiac index should be around 2.2 to 2.4 liter per minute per meter squares, and manage your cardiac index according to the hypothermia of the patients. And last but not least, keep the patients with the normal pressure and with the normal flows, and come up with the normal parameters. सवाल कर सकते हैं बीच में. So for the as a perfusionist for the Marfan syndrome patients, and especially for the aortic dissection or aneurysmal or even the mitral valve prolapse, so you have to discuss with your surgeon related before going on bypass for the cannulations, depth of your hypothermia. You have to keep ready your cell savers or ultrafiltrations techniques, because the patient might be going to bleed. So try to use ultrafiltrations to avoid the hemodilution of the patients, and keep the blood gases in a normal values. Keep your HCO2 in above than a 70. Pressure should be in the 50 to 70 millimeter of mercury. Pump flow and oxygen consumptions and oxygen requirement should be managed by the perfusionist. Of course, you have to fix to see your nurse. Keep your cerebral sets around the 50 and above, 15% and above. And good luck for your Marfan syndrome patient management. If you have any question, please don't forget to comments. We will try to answer you. We'll try to elaborate the procedure, how to manage it. This video is totally based on our clinical experience. So as a perfusionist, the most important is the communication between surgeon, perfusionist, and anesthetist. So time of the cannulations, especially if you're going to cannulate patient in the femoral, so keep your femoral cannula ready with the guide wires, with the percutaneous dilators. Or if you are going to cannulate in the axillary, sometimes you require the graft, so keep ready the graft by the nurses, and then cannulate patients with your preferred cannula. And have a nice and good day. Any question, please don't forget to comment. Don't forget to share this video with your perfusion community, and don't forget to comments and questions to me. Have a nice and good day.